Hey everyone, welcome to my medical school application series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my personal journey as a first-generation medical student. My mission here on YouTube is to give students all the information they need for a career in medicine.
There are a lot of different subspecialties. Microsurgery is probably one of the biggest bread and butter aspects of plastic surgery. Microsurgery refers to using either loop magnification, so those glasses with lenses you see people wearing, or an operating microscope. And this refers to reconnecting blood vessels or nerves for a variety of different purposes. A major thing that we do is oncologic reconstruction. So after breast cancer, head and neck cancer, skin cancers, soft tissue tumors, bone tumors, anything. Limb salvage is similar, reconstructing the limb after you have either cancer or trauma or some kind of wound, like a diabetic foot wound. Lymphedema surgery, it's sometimes called supramicrosurgery. It's where you're reconnecting lymphatic vessels, and these can be, 0.3 millimeters, so very small. Hand and upper extremity is another subspecialty that is actually shared with orthopedic surgery. So hand surgery, it refers to surgery distal to the elbow, and you can go into hand surgery either through plastic surgery or through orthopedics. This deals with bony diseases of the hand, also, soft tissue problems, reconstructing the hand as well, amputations and reattaching fingers or hands. Pediatric hand refers to congenital pediatric hand deformities, like the syndactylly shown here. Brachial plexus, so helping to repair reconstruct the brachial plexus for injuries. Peripheral nerve surgery is also important. I put it under hand surgery, but this refers to nerves all over the body. So patients who have either nerve injuries or painful neuromas, migraines can be treated surgically. Also, like things like pudendal neuralgia, decompressing nerves around the body. Aesthetic surgery, as we all know, so this is body contouring after massive weight loss, facial aesthetics, and most people are familiar with this aspect of plastic surgery. Transgender surgery, this is top surgery and bottom surgery for male to female and female to male. Craniofacial and pediatric are often lumped together. So this includes adult craniofacial trauma, but it also includes pediatric craniofacial surgery, which includes things like soft tissues, so cleft lip, but also bony deformities like craniosynostosis and other skull conditions that kids may be born with. Orthognathic surgery refers to surgery of the jaw and the mid-face. This can be for either facial aesthetics, for changing the shape of the jaw or the mid-face, or for things like opening up the airway if they were born with, issues with breathing. So I put this category here for other reconstructions. So this can include burn reconstruction, complex wound reconstruction, trauma reconstruction. And then finally, I put vascularized composite allotransplantation here. So, as we discussed on the last slide, you began with the first kidney transplant in the 50s, and now we have transplant surgery as its own specialty, and they're performing whole organ transplants. Plastic surgery today is very focused on the idea of composite allotransplantation. So this means transplanting composite tissue, so multiple tissue types together. And so this is mostly seen in face transplants, hand and upper limb transplants, abdominal wall transplants for patients who, have massive abdominal wall defects from either a tumor resection or from a military blast injury, penoscrotal transplants as well.
So residency, it's 3 years, but first you have to do 1 year intern year. I did mine in a surgical transition year, meaning it was pretty much a split up between medicine, surgery. I did some pediatrics, I did some intensive care unit work, and then just a lot of electives too. So that was good. I got a lot of experience. I actually did brain surgery once, so that was kind of exciting to get that under my belt. And then so I did residency for 3 years, and pretty much what that entailed was I worked in a private office setting, and also a hospital setting. Very different. The hospital setting is really where we store most of our pathology, and that's mainly where we operated as well too. It was actually, and no one really believes it until they see it firsthand, residency was quite difficult. And I say that because you're taking home call. So you'd work a busy day in the clinic or in the operating room, And then you would cover 4 hospitals. So if you were primary call, and that's what the first and second years were, you're covering 4 hospitals. Plus, they would get a lot of transfers, and I was out in Long Island, so all the private ophthalmology, or excuse me, all the private hospitals would transfer their ophthalmology patients to us. So even if you got a couple consults, you could be up all night and then working the next day. So that was actually pretty challenging. But you did get, again, you got a lot of good experience doing that. And I'd always say for anyone doing any type of training, as painful as it is in the beginning, you want to get that training, because then, when you're out of training, you know that this is something that you can handle, without a problem. So we did that, again, 30 years mainly when you're operating. And that's when you're doing your cataracts. That's our bread and butter surgery. So we did a lot of cataracts at the city hospital. And then we'd also operate it with retina people as well too in the private office. That was mainly assisting them. As we mentioned, retina is one of the more technical types of surgeries, and a lot of ophthalmologists do fellowships. I think it's about like 80-90% now. I'm a little bit of an anomaly, just doing general or comprehensive ophthalmology. But we'll talk about the fellowships in a second. What I do now, I work, as I mentioned, in a private office, but I also work in a city hospital. And that's nice. I work on the Lower East Side, and that hospital, we see a lot of pathology there, definitely a lot of language barriers, but it really is nice. Even with the language barrier, there are a lot of people there to, translate for me, and the patients are very appreciative. It's a slower pace. Again, it's nice. You're not really worried about any overhead there. You're just kind of making sure that the patients are being treated well. And again, a lot of pathology there. You're going to see just a lot of, different things. And then I also work in a private office. I work actually with my friend and his father up at Columbia University. I'm not staffed at Columbia, but my friend's dad works at Columbia University, and then he has a couple different private offices, which I work at. We see a lot of patients there. It's my friend and his father are very busy surgeons, and pathology really depends on where we are. But again, it's a lot of work, but at the same time, we have a lot of help there. That's a big thing, just having a lot of different staff to help screen the patients. They're checking vision for me. If a patient comes in wanting, a glasses check, they're taking care of that before they see me. And we have a lot of nice technology. So we get a nice big photo of the back of the eye before I even see the patient. Any testing that I need is already done. The staff is really good at anticipating my needs and what I might order for the patient. So that's really good. And again, for any real specialty, I'd say it's great to just have good staff, because they could, it comes to a point where they know what you're going to do, because, 80% of the time it's going to be, a similar thing. So it's good that they're able to do that. Again, kind of touches upon too about how I gave up operating, but you can still kind of find your niche, because my friend and his father just love doing cataracts. So it's a nice kind of symbiosis where I'm not trying to take their cataracts, and I'm just trying to, help them out and make sure that the patients get good pre-op and post-op care. What we do pretty much, it's a lot of routine just exams, people coming in to get their eyes checked. In pathology, we see cataracts, glaucoma, diabetic retinopathy, dry eyes, macular degeneration, chalazion. In what I'm doing a lot of office procedures, a lot of lasers, a lot of INDs, punctal plugs, and injections. And we'll get into that in 1 second. To speak a little bit about the OR, that really kind of depends on your specialty. For a retina person, they're doing, and again, not that these terms will necessarily mean a lot to people listening to this, but vitrectomy, that's basically like you're sucking out the jelly of the back of the eye. They're doing peels of membranes in the back of the eye. They're putting in gas, and that's all to kind of remove scar tissue and to put the retina kind of back into place for a variety of reasons, whether it's detached, something's pulling on it. But basically, that's what retina is doing. It's a very technical, complicated surgery that requires 2 more years after residency to learn how to do. But they're great. They're wonderful to watch, and if people want to learn more about it, I honestly recommend going on YouTube and try to watch them. You're probably not going to understand what's going on, because again, it is very technical, but I think it's worthwhile. Cornea specialists, they specialize in the front of the eye. Their main thing is corneal transplants. They'll either do a full thickness or partial thickness. I don't know if you've heard of people donating their eyes, but this is kind of what cornea does. They're doing the transplant. So you're donating the front part of your eye. And then for whatever reason, if there's scar tissue, if there's inflammation of the front of the eye that needs to be replaced, well, I mean, it's an amazing surgery. They'll remove the top part of the eye. They got to quickly put the new part in because the eye obviously does not like being open for that long. It has a bad kind of pressure gradient. So you're kind of asking for bad things to happen when the eye's not, when the eye's open like that. So they got to put the graft back in, suture quickly. They'll do other types of things like biopsies. So if the pressure is too much in the eye, they'll kind of create another pouch for the fluid to go through. Again, that's a oversimplification, but that's kind of what they're doing. And then there's other new surgeries, minimally invasive surgeries that are usually done with cataract surgery they don't work as well, but the complication rate is much lower. And that's a big thing with glaucoma. They're getting because someone could come with a pressure of 40, you do one of these surgeries, and then the next day they're coming in with a pressure of 0. And then it's like, well, now great, now we gotta get the pressure up. And patients are not happy when that happens because again, glaucoma they were seeing fine, and now you're messing with their eye, and it's tough. Pediatrics, we haven't really spoken about that. This is another great field because strabismus surgery, that's basically eye misalignment surgery. What we're doing there is really just reattaching the muscles on the eye. The eye has a lot of different muscles being attached to it. Kind of just imagine just almost like a puppet being kind of moved back and forth. And if the eye's kind of going out one way, we'll just kind of adjust where the muscles are. And that can straighten out someone's eye. And you want to talk about, really impacting someone's life. You see someone who has strabismus and you get their eye straight, they're forever grateful for you. So that's another wonderful surgery that you can do. Ocular plastics, they're doing anything around the eye. Blephs are a big thing that they do. Everyone wants to have their eyelids worked on, but they're doing a lot of non-cosmetic stuff, mainly non-cosmetic. Orbital floor fracture repairs, they're doing the tear system repairs, eyelid reconstruction, and if there's any type of orbital tumor, they're doing it along with either ENT or possibly even neurosurgery. That's another kind of difficult subspecialty, another 2 years of training. Also, very few of them. So it's always good to kind of get a good relationship with an ocular plastic person because they can be very difficult, cases and surgeries. Cataract surgery, it's our bread and butter. We already mentioned kind of replacing cloudy lens with a clear plastic lens. What we're doing is, again, we're breaking up the old lens with an ultrasound probe, sucking it out, sliding a new lens in.
So why psychiatry? I think there's a real neat aspect here of you being able to help people to empower themselves to solve their problems. You think critically about aspects of your patients' lives and you draw up multiple disciplinary solutions in concert with others. It's very intellectually rewarding and personally as well. There is a sense that there are very few clear answers for problems. And for some people that can be really frustrating. For other people that it is really exciting. And there's a lot of overlap. Like I found when I did rheumatology rotations, actually, that there was a lot of overlap there too, and that psychiatrists and rheumatologists often got along for that because they're just not very clear answers to rheumatologic problems. You learn a great deal about yourself through the training process, which I think it can be true of any residency, but I think is like part and parcel of psychiatry. If you're doing it well, you should be getting more insight into yourself. And then therefore the skills you learn in life are really invaluable because you can apply them in multiple ways in your own personal life as well. A couple of things that I think are really, now I've realized is that, there is some ageism in our society, and if you do procedure-based specialties, you have to be able to continue to do them, right? Whereas as you age in psychiatry, the breadth of knowledge you develop actually makes you more esteemed, even if your physical skills start to deteriorate a bit. And the practice is very flexible. So it's still possible in psychiatry to be your own boss, whereas in many other specialties, it's really very challenging to just hang out your own shingle and do it yourself. And there are many psychiatrists who do some combination of, their own clinic and then working part-time in other settings as well. And I think that brings some job satisfaction related to that. So a day in my life, a lot of it has to do with what my personal life is. I get woken up with my kids really early. I help my family prepare for the day. I'm really happy now. One of the things I get to do is walk to work, right? And it is really important to me to think a little bit about how our work intersects with things like climate change, and that's something I think is really, can work with mental health as well. I get to work and we discuss the learning objectives and to-dos with staff and students. We get the morning report. We intake new patients and round on remaining patients. And the real core of it is these treatments, which I'll get into a little bit more. A couple of days a week, because I'm still in training. One of the days I have an outpatient clinic, and the other one I have didactics in the afternoon. And the afternoon is really, after I go home, is really meant to be more of like my personal experiences, exercising, doing some, like started a garden during the pandemic and really like it. And then spending time with my kids. The cases are complex. So, what I tried to do is some composite of things of things I've seen here, because the nature of psychiatry and the intimate work we do, if I try to individualize anything, it doesn't work out very well for that person. So if we take this example, which I think I'll try to walk through, an adolescent presenting with suicidal ideation. So what's going on with that person? The patient has been more reclusive, withdrawn since the COVID-related lockdowns and the George Floyd-related racial unrest. And the person explodes with anger towards parents, stating that the parents invalidate their opinions, is now failing school despite being a high-achieving student previously, and it's mostly online school now too. And they wound up telling a friend that they were thinking of killing themselves, and the friend notified police. No previous interaction with the healthcare system beyond routine well checks with the pediatrician. And on exam, which I've seen, frequently the patient can will selectively answer questions and otherwise remain silent or sobs profusely. And the first thing I do in this setting, right, if I'm, this is a kind of a case I would see maybe perhaps in the ER, is my job is to decide what is the least restrictive treatment that can be applied to this person. Does that mean inpatient hospitalization, where, the nature of an inpatient psychiatry ward is that it's a locked unit. You have restricted access to the outside world. And so there are some real downsides to someone coming in. And that's why we think of what's the most beneficial way to treat this person, which may not be necessarily in the hospital setting. But there are times when we determine it makes sense for the person to be in the hospital because they may be a danger themselves very quickly, but the patient may not want it. And that's also a challenge too. And that's a really kind of fascinating part about psychiatry that we work through. I won't get into much detail about this, but it is kind of a unique aspect of, well, maybe not unique, but an interesting part of what we do. Well, what if an inpatient hospitalization is what we don't need, but an outpatient clinic treatment makes sense, or somewhere in between? And there's this kind of structure in psychiatry of, okay, well, the inpatient hospitalization, and then maybe you have places where you go during the day, but then you go home at night, or you're just having your kind of, clinic appointment that you have every so often. I think when we talk about this biopsychosocial model, that it's helpful to diagnose, sorry, let me move this a little bit, diagnose how we treat people. And what we think of is really the continuum of how a person interacts with their society. So, we can affect change as physicians at an atomic level, subatomic level with medicines, with interventions, with procedures, but people don't live by themselves. They live in an ecosystem, and that ecosystem also affects them. Maybe the family, the culture, and the society, and the nation. And in order to really effectively treat someone, you ought to be thinking about how all these experiences kind of combine together.
So this is obviously a very distilled version of what a day in the life of a pathologist is. Can vary depending on your practice type, academic versus private practice, large teaching hospital versus some sort of community hospital, and also the type of pathologist. So forensic versus surgical pathologist versus a cytopathologist. There are also people who practice primarily a subspecialty, like neuropathology or renal pathology. I'll go over a little bit more of a surgical pathologist day. So this is the most common type of practice in pathology. And this is basically a physician who diagnoses mostly tissue from surgical patients. So biopsies, surgical resections. So a surgical pathologist spends a lot of their day at the microscope examining patient material. During surgeries in which the team or the surgeon needs some sort of histologic diagnosis, they send us tissue, which is then processed by the pathology and histology lab. And some pathologists will either oversee or participate in what's called grossing. So that's where we look at the tissue macroscopically, so not under the microscope, to be able to glean information regarding the diagnosis and determine what parts of the tissue actually need to be submitted and reviewed by a pathologist. So once the slides are ready, we as the pathologist review the patient's clinical information. We look at all their imaging, all their labs, and then examine the slides under the microscope. And then sometimes we can come to a diagnosis immediately. Sometimes we need to order additional tests. Molecular testing, for example, is becoming ever more prevalent and important in our diagnosis. And then we render a diagnosis as well as a detailed pathology report. If there's something unusual or unexpected for the case, or we need more clinical information, then we will call the clinical team, the ordering physician, or if the imaging doesn't seem to match up with what we're seeing, we'll call the radiologist to discuss further. If we're on call for what we call intraoperative consultations, then the day can be admixed with being in the surgical pathology lab, actually reading what we call frozen sections. So if while a surgeon is operating, they feel they need more urgent macroscopic or microscopic information to determine the next steps of the surgery, they'll then request what's called an intraoperative consultation, also what we call a frozen section. So they'll send us a small representative portion of the lesional tissue, and we do a rapid form of processing. And then we try to address whatever question that they have. It can range from wanting to know if they do in fact have enough lesional tissue. Are they in the actual lesion versus normal tissue? Do we have enough tissue to do molecular testing or to render our own diagnosis? Or do they want an actual diagnosis in order to determine how to surgically proceed? So frozen sections for us are high pressure. They're much harder for us to interpret because the processing is usually suboptimal, very rapid compared to our normal processing. And we try to do this very rapidly because the patient is under anesthesia. And we try to minimize as much time and exposure to anesthesia. So a common example of an IOC or an intraoperative consultation in my field is when a neurosurgeon will ask whether am I actually in brain tissue or brain tumor tissue? Am I in lesional tissue versus normal brain? Or is this neoplastic tissue like a glioma or a brain tumor versus reactive brain tissue, which is a brain that is normal, but it's reacting to some sort of injurious result. So if we diagnose a tissue as glioma, the surgeon will then proceed to resect it. But if we call it reactive, they'll leave it in. So you can see that's a lot of pressure for us to be able to get the diagnosis right. We don't want to incorrectly call the tissue neoplastic or glioma and for the surgeon to then resect normal tissue. So frozen sections are a big part of our day if we're on call for that and can be pretty high pressure. Other parts of the day include attending conferences. We have consensus conferences. We show our difficult cases to other pathologists. We also have multidisciplinary tumor boards where we meet with radiologists, surgeons, oncologists, a variety of other physicians from other specialties to be able to discuss current cases and treatment plans. We also attend grand rounds, journal clubs, and all of this depends on if your practice environment is, for example, an academic or a large hospital. One of the common misconceptions is that pathologists are more basic science and don't interact with people. But we actually play an immense and direct role in clinical care, as I alluded to previously. Our diagnoses are essential to being able to form treatment plans. And some pathologists actually even do procedures. Cytopathologists, a branch of pathology, actually does, in some institutions, fine needle aspiration procedures on on patients. And there's actually another branch of pathology called clinical pathology, in which the pathologist has an integral role in a large majority of the hospital tests and procedures. So they assure the quality of all the lab tests in the hospital, to managing the entire blood supply for the institution, assessing transfusion reactions. We're also constantly interacting and collaborating with other pathologists, surgeons, oncologists, physicians from other specialties, all trying to deliver high quality patient care. So we're often called the doctor's doctor because we interface largely with other physicians. But I think this incorrectly belies the direct impact we have on patient care. We're a doctor's doctor, but we're also the patient's doctor as well.
All right, so my name's Hillary McCray. I'm a resident physician at the University of Utah, where I'm doing a 5-year training program in otolaryngology head and neck surgery. And so you might be asking yourself when you see the slide, what is otolaryngology head and neck surgery? And might not know much about that. So I'm going to kind of give you a brief preview of what I do on a day-to-day basis. So kind of when you look at what is on the national websites in terms of the American College of Surgeons. So otolaryngology is a type of surgical subspecialty, and you kind of look at how they define what our career is. And really kind of the emphasis of what I do on a day-to-day basis as a head and neck surgeon is I am trained to take care of the surgical and medical needs of patients that are presenting with various different types of head and neck pathologies. And kind of what that means in terms of what types of disorders and anatomy I'm dealing with is, so it could be anywhere from an ear infection that has gotten very complicated and is approaching the skull base, could be a respiratory infection that's causing acute stridor, or anything that's kind of causing obstruction in the nose and the upper airway. And really, we're dealing with some very complex anatomy and diseases in the head and neck, which is kind of the appeal for a lot of people that are interested in a career in head and neck. But really, how the American College of Surgeons defines what an otolaryngologist does is they basically said that we are understanding the basic medical science relevant to the head and neck, and how that can go on to affect your ability to hear, your ability to communicate with one another, and your chemical senses. And one of the things that really drew me to a career in ENT is that I deal with people's innate senses, whether that's their ability to smell, their ability to hear, their ability to see. All of those things we really are able to have a direct impact on our patients. And so, we're able to take our medical expertise of this very complex area and then offer complex surgical solutions to patients that have a variety of head and neck needs. And those can range from, doing a simple tympanoplasty for someone that has a hole in their eardrum, or if it's someone that has a very complex cancer that's invading, somewhere in their oral cavity, like their tongue, and then it has, disease that's spreading to their neck. We're able to really address all of those very complex needs for our patients. And so what does the training entail? So like any surgical subspecialty that usually has a minimum of 5 years. So I'm in a 5-year training program. The first year, your intern year of residency is spent usually doing 6 months of otolaryngology and then 6 months of training with either plastic surgery, neurosurgery, which we work very closely with our neurosurgeons for a lot of different types of complex cases. General surgery, kind of learning how to take care of, post-operative needs among children and adults that are having different types of general surgery. Intensive care is also an innate part of your intern training. Usually we do about 2 to 3 months of intensive care. In terms of my training, I spent time in the burn unit, on a surgical shock trauma unit, and then in the neuro ICU as well. And then we also work with our anesthesiologist because airway management is a pretty large part of what we do as otolaryngologists. We're kind of the airway emergency experts in addition to our anesthesia colleagues. And so really it's that relationship with other specialties that kind of allow you to build on the skills that you need to be successful as an intern. And then research is also an innate part of what we do as otolaryngologists. I think, anyone that's considering a career in ENT has some, interest in kind of expanding the medical knowledge about our field. And so usually there's some sort of research component built into your residency education. For me, I do about 6 months of research that's kind of spread out over the course of the 5 years, but there are some programs where you can do just a year of dedicated research, or even 2 years where you're under a special grant that allows you to kind of expand research opportunities on the national level. And then really the training, like we had kind of previously talked about, is a mix of operative experience and clinic time. And it's kind of, the ability to take care of patients in both of those capacities. It's very fulfilling. So what are the subspecialties of otolaryngology? So there are a lot of them, and you can go on after your 5 years of training to go ahead and do a fellowship. One of them, it could be rhinology or skull base training. So any diseases that affect the sinuses, the nose, nasal obstruction, or even tumors that are going, in around the sinuses and kind of invading up near the skull base. And that's when we could kind of collaborate with our neurosurgery colleagues. You could go on to be a facial plastics and reconstructive surgeon, so addressing the various cosmetic needs of patients, anywhere in the head and neck. And, also associated with that is a reconstruction. So either, with local flaps or free flaps, which I can kind of talk about a little bit later, head and neck surgical oncology, which is my field of choice and what I will be applying to fellowship in. And really, you are a head and neck cancer surgeon, and you deal with patients that come in with a variety of head and neck cancer needs, or even endocrine needs in terms of thyroid, parathyroid care. And then also you're trained to be the reconstructive surgeon for those. And so sometimes that means that you're taking, someone's thigh and reconstructing their tongue, or, taking part of their forearm and reconstructing their tongue, and then doing the associated microvascular reconstruction for that. And really, it's a fascinating field, which is why I chose ENT in the first place, was because of head and neck surgery. Laryngology is addressing people's voice and airway surgery concerns. So people that have, difficulty breathing due to narrowing of their airway, or if they have, a particular injury to their recurrent laryngeal nerve that causes them to have a vocal fold paralysis. Being a laryngologist allows you to kind of, improve their quality of life related to voice and breathing. Neurotology and otology is what you would consider an ear surgeon. So they're trained on kind of lateral skull base, and then any ear needs, including cochlear implants, which have a massive impact on the quality of life of other people that have, deafness or hearing concerns. And so really that, again, has a massive impact on people's quality of life. Pediatric otolaryngology, which I'm currently a resident on that service. So you're addressing basically all of the head and neck concerns among children. And so they're kind of like skilled in providing complex head and neck care to patients that have acute sinus concerns or a neck infection or even hearing concerns. And so they are able to take care of many different aspects of children with unique needs. And then sleep medicine and surgery is kind of a growing fellowship within our field. So you can offer surgical options for patients with really bad obstructive sleep apnea. And overall, most of these fellowships are 1 year. So most otolaryngologists that are fellowship trained will be done in about 6 years. Neurotology is 2 years, and then some head and neck fellowships, some facial plastic fellowships could be 2 years as well. So what does my day look like? I round pretty early. I get up pretty early. I usually get up around 5 a.m., 5:30. I go in, I round. I'm currently the chief on the pediatric otolaryngology service. So I meet up with my other residents on my service. We see our patients. And then around 7 to 8, we talk to the attendings about their patients. And then we go to the operating room or the clinic. Usually, if I'm in the OR, I'm there pretty much all day dealing with add-on cases. I could also be in the clinic seeing patients for new consults or postoperative needs. And then we round again in the afternoon, go see how our patients are doing throughout the day. In terms of call, we are consultants. And so we get consulted by various medicine specialties or surgical specialties and the ER to come and see patients with a variety of head and neck needs. And so that's another aspect of being an otolaryngologist, is you're a consultant that goes sees, people that have, acute head and neck needs. Why should you consider a career in ENT? Basically, you can improve the quality of life and someone's life trajectory among patients that are facing a variety of different diseases that affect the head and neck. I think it's a really good mix of clinic and surgery. I think that, you're not purely in the OR, and you are also able to help patients in the clinic as well, with even just kind of like local procedures that can be done while the patient's awake. What I also like about it is I treat kids, I treat adults, I treat men, women, basically whoever has an acute head and neck need, they can come and see me. And so I don't, I'm not limited to just seeing, children. I can see basically anyone that presents to my door. I also think that otolaryngologists are really happy with their career, are very easygoing, even though, you could think of surgeons as being kind of like maybe more of a rough crowd. I think otolaryngologists are really happy and they love to teach. And I think that that was another thing that really appealed to me, is that they are very, lovely people to be around. And then, there's the potential to go into a variety of subspecialties after otolaryngology. It kind of lists some of the options. Really the anatomy of the head and neck and the pathology that we get to treat on a day-to-day basis is amazing and really fulfilling.
What is orthopedic surgery? Orthopedic surgery is the treatment of musculoskeletal disorders, and that includes the treatment of bones, muscles, ligaments, tendons, nerves, and the skin and soft tissue. It's fairly comprehensive. It includes just about everything outside of the head and the abdomen. But I do know some orthopedic surgeons that will venture into the back part of the skull and the front of the spine here, and also we'll do some rib surgeries, as well as some abdominal flaps. So it doesn't necessarily limit you to these things. I think the field of orthopedic surgery is very wide and almost all-encompassing. Treatment is largely geared at restoring function and eliminating pain. There's many reasons why people seek out an orthopedic surgeon. Typically, we all think of a broken bone as a reason to go seek out an orthopedic surgeon, but chronic debilitating arthritis, low back pain, numbness and tingling in the fingers, these are all reasons why people seek out certain subspecialists. Pain is usually one of the reasons why people seek out help in the first place. And then when the etiology of that pain is deemed to be something that's related to the musculoskeletal system, often those patients are referred to us. Orthopedic surgery requires an in-depth knowledge of many surgical subspecialties blended into one: principles of general surgery, plastic surgery, neurology and neurosurgery with peripheral nerve surgery, physical medicine and rehabilitation, and even physical therapy. So it is a fairly wide encompassing practice. I think these are some images that are representative of some of the types of injuries that we see on a not so irregular basis. This is, I think, what classically comes to mind when people see or think of an orthopedic surgeon. We deal with a lot of radiology and medical imaging. These are x-rays of various body parts, ranging from a forearm on the left to a distal humerus in the bottom right-hand corner. And then this is the bottom middle image on the left is probably what Tiger Woods just had, and that came out in the news recently. He had a shattered tibia and a fibula fracture. So that's a part of the lower extremity. And I think these are classic images of what we think of as orthopedic surgeons, but it's not just that. Orthopedic surgeons then treat these fractures and broken bones and problems with a variety of tools. We call those implants or medical devices. Usually they're made out of a stainless steel alloy or titanium in some instances, or various blends of metal. And these may be representative of some of the things you can pick up at Home Depot. We put in plates, we put in screws, we put in bands, we put in wires, we put in rods, and these are all part of our literal toolbox. From a day-to-day, what does the life of an orthopedic surgeon look like? Well, I think there's significant variety based on a specialty. And the specialties within orthopedic surgery are many. There are hand surgeons, there are joint replacement surgeons, there are spine surgeons, there are foot and ankle surgeons, there are sports trained surgeons, there are fellowships in trauma surgery, shoulder and elbow surgery, a newer burgeoning field that's a hybrid between neurosurgery and plastic surgery is called orthoplastics, or reconstructive microsurgery, that deals with connecting cut nerves and even doing nerve transfers to increase or provide functionality to patients' limbs. There are general orthopedic surgeons, so people that just do a little bit of everything. And then there are orthopedic oncologists, so tumors of the musculoskeletal system. And then finally, there is a field dedicated just to children in pediatric orthopedics. All of these are fellowships that you can do after you finish your orthopedic surgery residency training. And we'll talk about the residency and fellowship process in just a minute. But the day-to-day life and what types of patients you see as an orthopedic surgeon can vary tremendously based on your type of practice and also what kind of surgeon you choose to be. If you're a general orthopedic surgeon, you'll see a little bit of everything that walks through the door. In today's day and age, I think there's a trend towards increasing subspecialization. So within the field of orthopedic surgery, you'll have at a single hospital or a practice, you'll have multiple fellowship trained orthopedic surgeons each covering a different domain of the body. So the hand surgeons will deal with the upper extremity. The joint replacement surgeons will typically do joint replacement surgery and complications that may arise from that. Spine surgeons do spine surgery. Foot and ankle surgeons do foot and ankle surgery, etc. That is increasingly common as time goes on. There is a mix of inpatient versus outpatient surgery. There's an increasing trend towards the ability to operate as an outpatient. So patients come in, they do a regional anesthetic, meaning that they have a peripheral nerve block from the anesthesiologist that numbs their extremity that they're getting operated on. They have the surgery, which could last, less than an hour to multiple hours, and then they go home the same day. That's termed outpatient surgery. Inpatient surgery typically is reserved for more complicated or risky procedures, or patients that may be at a higher risk of having surgery. So they either have multiple comorbidities that preclude them from being operated on as an outpatient, or they may have multiple traumatic injuries and they may not be stable enough to have surgery done as an outpatient. Say, for instance, a patient who got into a motor vehicle accident that has multiple problems and not just musculoskeletal complaints. So say maybe they have abdominal injuries that general surgery or trauma surgery is managing, but they also happen to have a forearm fracture. Well, those patients typically will be managed in the hospital until they are well enough to be discharged outside the hospital. So as an orthopedic surgeon, you will manage both inpatient and outpatient surgeries. And then finally, there are multiple types of practices, and it's largely up to you which type of practice you wish to join. You can do academic medicine, where you work at a major academic medical center. And typically, academic orthopedic surgeons are subspecialized, and there may be multiple subspecialists within your own department. You can still go into private practice. Private practices can be multi-specialties. So you may have any of these varieties of specialties in your practice, or it could be single specialty. You could join a predominantly upper extremity practice, or you could join a predominantly sports practice. And even you could just be a surgical practice, and you could have orthopedic surgeons and also urologists and ear, nose, and throat doctors also working at the same service center that you may have a share or stakehold in. And then finally, there are orthopedic surgeons that are employed physicians. So they're employed by a hospital system, and there are many hospital systems throughout the country. That's typically how orthopedic surgery works, and the variety of practices that exist. So what is my day or how much, I guess, so we should go on to that. How much do orthopedic surgeons earn? Typically, they're at the higher end of the spectrum. This varies from year to year. In this particular year, orthopedic surgeons were at the top of the list. Now, if you go into subspecializations, increasingly at the top of the list, there are interventional cardiologists. So who place minimally invasive, who place stents and other valve replacements minimally invasively. And neurosurgeons or spine surgeons also tend to be at the top of the list. This is, in general, this list here is general practitioners. So in general, orthopedic surgeons are well compensated for what they do. I would say the average orthopedic surgeon probably works about 60 hours a week. That's about 12 hours a day or less, but then taking call on the nights or the weekends. So I think from a work-life balance standpoint, it's very good. I don't have any complaints about my work-life balance. I think in any profession, your work-life balance is what you make of it. You can do anything you want to as a physician, and you can be as busy or not as busy as you wish to. And I wouldn't shy away from joining a surgical subspecialty or a surgical specialty because you think that you're not going to have enough time to have a work-life balance. I think the field of orthopedic surgery is increasing. It has historically been underrepresented by women, but that trend is reversing, and there are increasing numbers of women that are choosing to go into orthopedic surgery and many surgical subspecialties outside of orthopedics. I think it's a phenomenal field for just about anyone who wishes to do that. And so the work-life balance, I think, is fine, and they will differ depending on what type of orthopedic surgeon you are. If you are a trauma surgeon and you are on call more, you may not have as much of a work-life balance as someone who operates almost exclusively at an outpatient surgery center, where those typically are open only between the hours of 7 and 5 p.m. So that's a little bit about the lifestyle and compensation of an orthopedic surgeon. How do you become an orthopedic surgeon? Well, you have to match into an orthopedic residency, and then fellowship is optional. I think most people choose to do a fellowship these days, and I think for good reason, because we're increasingly subspecialized, but the number of surgeries and what we can do as orthopedic surgeons is expanding on a day-to-day basis. The operations that we were able to do 20 years ago are far and few between compared to the operations that we can do today. I think the number of surgeries and the scope of practice that has increased offers the increasing interest in doing more training. And some people choose to do even 2 or 3 fellowships because they want to become a certain type of subspecialized surgeon that only specializes in, say, hip preservation surgery or a specific type of pediatric surgery. Typically, an orthopedic surgery residency will have 1 to 14 residents per year. There are about 120 plus programs in the United States, and about 800 to 900 residents will match per year. It is competitive. I would say that's probably about 75% of the applicants. So 25 to 35% of people will end up not matching into orthopedics and will have to either reapply or do something else. Orthopedic surgery residency is 5 clinical years. As an intern, you'll do 6 months of general surgery and other rotations that are foundational for the practice of orthopedics, including radiology and managing patients in an intensive care unit. Some programs do have an optional research year for interested residents. So though that makes their residency program 6 years. Typically, those slots you have to apply to directly. So if you're interested in doing a research year as part of your residency program, you may have to apply specifically to that spot at that program. Intern year typically is a mix of floor management and the introduction to the operative experience. Each program introduces their residents to the operative experience differently. Some programs will have a large operative component to their intern year, and some programs will not have a large operative component to their intern year. Intern year is important for you to learn how to take care of patients after surgery, before surgery, and any complications that are medical that arise from surgery. PGY 2 year, or the second year of residency, is typically the consult year. So you carry a pager. And when there are emergencies or traumas, such as the one that we saw previously on the slide previously, when those come into the emergency department, you usually are the first line clinician. They will call you and say, I have an orthopedic consult for you, and you will go see that patient in the emergency department. There is a trend towards adding increasing operative responsibilities as a second year resident. And then years 3 through 5 typically are largely operative. You usually will still have a mix of call in there. You will have chief resident responsibilities, and you will be directly responsible for directing the management of patients that come into the emergency department. You may not be the one physically evaluating the patient, but your junior residents, when you're a chief resident, will run consults by you. They'll call you and they'll ask you for your help. They'll ask you what to do with the patient. There's sort of a ladder approach to managing patients and determining how to treat them best. And then when you graduate, you have the option to complete a fellowship. All fellowships in orthopedic surgery are 1 year. There are a handful of 2-year fellowships that typically add on a research component, but that's not common. So any of the fellowships that we previously talked about, sports, foot and ankle surgery, spine surgery, all of those are 1 extra year of subspecialization where you pretty much just do that type of surgery. So the match process, if you don't match, you'll typically receive an email on the Monday of match week that says, I'm sorry, you did not match. Then there's the opportunity to participate in what is layman's terms called the scramble. And you can, the match process is not perfect. There every year are unfilled slots of residency programs across the country and just about every specialty. Depending on the year and how competitive it is and how the match process works, there may or may not be available orthopedic residency slots that went unfilled. If there are, you have the chance to vie for those through the scramble process, in which case you continually apply. Program directors may call you and say, I have an open slot here. I'd like you to rank this. So there's multiple match processes that go on Monday through Thursday of match week if you don't match, depending on what slots didn't match. So if you don't match and there is an orthopedic residency slot that also went unfilled, you have the opportunity to match in that program. If unfortunately, as tends to be the case, there are no unfilled orthopedic surgery spots, you could vie for anything else that you may have interest in. So you could vie for an internal medicine spot, or you could vie for a general surgery spot or a neurosurgery spot, if those are of interest to you. Typically, students that don't match have two options. You can either vie for what's called a preliminary slot in general surgery, where you start your intern year and you do a year of general surgery. We'll talk about that in just a minute. Or you can take time off and delay your graduation and do that year of research that I was talking about before, where you partner with an orthopedic surgeon, you do research for them, and then you reapply the following year with a stronger application, better letters of recommendation, perhaps, and hopefully more publications. The success rate for students that tend to do that is good. They've reworked their application, they've thought through the reasons of why they did not match, and they strengthened their application with better letters and with better network connections and more papers.
Right.
If you choose to go ahead and match into a preliminary general surgery spot or a preliminary spot in some other specialty, that year that you start your residency is it. You have to find another job after that year. So it's not a guaranteed or categorical residency position. So you start your residency program and you finish your intern year, but during your intern year, you'll have to apply through the match again to any subspecialty. Doing an intern year in a preliminary general surgery spot allows you the opportunity to apply into a variety of specialties, ranging from radiology to vascular surgery. And typically there are multiple slots that open up throughout the year or even beyond. The advantage to doing that is that you have the ability then to not only apply for intern spots across the country in various specialties that you qualify for. There's no right or wrong approach to doing that. It just depends on that student who unfortunately didn't match, their interests, their life goals, their family responsibilities, and their overall application. It is competitive, and not everyone is qualified to get into orthopedic surgery based on the metrics that programs are looking for. And so it is often a difficult conversation to have with those students, and it is disappointing when you don't match. But it's not the end of the world. They say where there's a will, there's a way. And I think for the motivated and diligent and dedicated student that's willing to be a little bit creative and definitely work very hard, you can certainly end up doing what you want to do even down the road. There are 4 different ways to become a hand surgeon. You can do general surgery, followed by a plastic surgery fellowship, followed by a hand fellowship. That typically takes 5 to 7 years for general surgery, 3-year plastic surgery fellowship, and a 1-year hand fellowship. That's a long time, but there are plenty of people across the country that do that. There are plenty of general surgery trained hand surgeons, and that is the route to become one. You can do what I did, orthopedic surgery, which is 5 years, and a 1-year hand surgery fellowship. That's the fastest way to get there. You can do plastic surgery, which tends to be about 6 years, sometimes 7, depending on the program, because they usually have a research component integrated into the plastic surgery residency program, and then followed by a 1-year hand fellowship. And then finally, the most exotic that I've ever heard of, and yes, there are surgeons around the country that have trained this way, you can do otolaryngology, which is ear, nose, and throat surgery, followed by a plastic surgery fellowship, followed by a hand surgery fellowship.
Wow. So
when they say where there's a will, there's a way, there is. You can become a hand surgeon if that's what you choose to be, 4 different ways. So any other questions about those? All right. So my typical week, I said I'm a fellowship trained hand surgeon. I typically have 2 to 3 days of clinic. I'll see anywhere from 25 to 60 patients on any given clinic day, depending on how busy it is. And then depending on the week, I may operate 2 to 3 days during that week. Those are typically elective surgeries. So patients that I see as an outpatient that come to my office and we discuss their needs and their desires for surgery, and that they are scheduled electively, typically at an outpatient surgery center, and that is where I operate. If there are any inpatients, I will round on those throughout the week as needed. Hand surgery tends to be a fairly good work-life balance because it is largely outpatient surgery. I rarely have inpatients. The only inpatients that I typically have are those that I needed to operate on who had multiple comorbidities, as we discussed, or who had surgeries that were riskier, or who had traumatic events and they were unstable and they came into the emergency department and were admitted as an inpatient. I do take call. Call responsibilities vary from practice to practice. There are practices where you don't have to take call. And then there are practices where you might be on call for a week or more at a time, 24/7. There are two or three different types of call as an orthopedic surgeon. You can take general orthopedic call. So any orthopedic complaint that comes into an emergency department, they just call you because you're the general orthopedic surgeon, or you're the orthopedic surgeon taking orthopedic surgery call. Sometimes hospitals will parse out a specific hand surgery call. So if they have someone that has an amputation of their finger or a laceration to the hand or any traumatic hand event, they will call whoever is on the hand surgery call schedule. Sometimes those call schedules are shared with plastic surgeons, or maybe even the ear, nose, and throat surgeon that did their fellowship training in hand surgery. Finally, there are hospitals that will offer a spine call. So spine trauma tends to be only neurosurgeons and fellowship trained spine surgeons that will take dedicated spine call. So I don't take spine call because I'm not a fellowship trained spine surgeon. But those are typically the three types of call that you may encounter as an orthopedic surgeon. So that's my typical week on any given basis.
So first, I'm going to just start with a typical day as a dermatologist. Of course, it depends on what type of dermatologist you are. So there are actually multiple types of dermatologists. You can be what's known as, probably by most people, a medical dermatologist who sees patients in the office and sees patients of all ages. So that would range from pediatric all the way to geriatric. Then there are specific pediatric dermatologists who will only see pediatric patients or children. We have Mohs surgeons, and Mohs is a type of skin cancer surgery. It's Mohs micrographic surgery. And basically, a Mohs surgeon is someone who is trained in treating skin cancers. And this is a very special technique where the skin cancer is removed in stages. And the same surgeon is also trained in looking at the specimens under the microscope to determine whether there's any cancer cells still remaining. There's also dermatopathologists. So these physicians are doctors who are dermatologists, but also have additional training in pathology, so they can read slides, specifically biopsies from skin. And we have cosmetic and laser dermatologists who may only, let's say, specialize in cosmetic and laser procedures. So again, the typical day depends on what type of dermatologist you are. I would say that most dermatologists practice a combination of medical, surgical, cosmetic, and laser dermatology. So that's one of the fantastic parts about derm, is there's a lot of variety, which entails seeing patients for medical visits, for skin checks, for acute visits, being able to do your own surgeries, and then also being able to engage in some cosmetics and lasers. So again, to my point, a variety of patients and procedures, all in an outpatient setting for the most part. There is part of dermatology that is developing now more as an inpatient dermatologist, someone who does consults at the hospital as well. But typically a dermatologist is going to see patients in the office. You know, for me personally, my day starts around 8:15. That's when my first patient is scheduled. And I have patients every 15 minutes throughout the day, apart from my lunch break. And usually my last patient's at 4 p.m. And as an attending now, I do work 4 days a week. And interestingly, as a dermatologist, there is perhaps some call or hospital call involved. I personally work in a private practice, but prior to working in the private practice that I'm at, I was in an academic department. And when I was in an academic department, even as an attending, I did have call, which meant I did have to cover the hospital consults. So that those are patients who are hospitalized, maybe for other reasons, but then happen to have a dermatologic emergency or a skin issue that's more urgent and needs to be seen at the hospital. And so depending on the practice that you're at, you may actually have to cover call or hospital call. Call may also mean that you have to cover patient phone calls. So just after hour emergencies, let's say from surgeries and so forth. And as a dermatologist, I would say typically you see patients every 15 minutes in clinic. Obviously, some patients, patient visits take much longer than this. Some patient visits are shorter than this, but this is how we're scheduled. And then, depending on the way your days are divided, you may have a surgical day. For me, for example, on Wednesday afternoons, I do mostly all my surgical excisions, which means I'm taking out skin cancers. I am taking out cysts, maybe lipomas, which are fatty tumors. And then I do have a cosmetic day. So these are the days, or laser day too. These are the days where I may do more cosmetic procedures. So this would entail injectables like toxins and fillers, and then lasers, which we do for a variety of reasons. So there's a lot of different things or components to my day. I love my procedures, which also I should say dermatologists do a lot of small procedures like biopsies. But I really think at the end of the day, my favorite kind of visit is a visit where I've seen a patient for a rash that let's say they've gone to other doctors for who didn't know what it was. And I've biopsied it. I've gotten a diagnosis. We've discussed therapy. And I put them on a medication which has totally cleared their rash and changed their life. So for me, that's actually the most fulfilling type of visit. So, and of course we have lunch in the middle of the day. At the end of the day, a lot of times I'm reviewing my biopsies. So these are biopsies of skin that I have done on my patients. I get the results back. I'm looking at the results and following up with my patients if they have a skin cancer, let's say a melanoma, returning patient calls, and just wrapping up my charts through the electronic medical record system. All right, so dermatology training. So this is basically, what it takes to be a dermatologist after medical school. So after 4 years of medical school, we start our residency. And for dermatology, we have to match into both a 1-year preliminary residency. So you can think of this 1 year as sort of like a general residency, and then the dermatology residency itself is 3 years. Okay, here we go. So in essence, dermatology training, dermatology residency training is 4 years total. This first year can be in internal medicine. That's personally what I did. I did what's called a preliminary internal medicine year. It could actually be done in general pediatrics. It could be done in general surgery, or there is such thing as a transitional year residency where you kind of get a little taste of all different specialties. And then you have 3 years of actual dermatology residency. You do take your dermatology boards exam to be a board certified dermatologist at the end of residency. Typically, this is in July after your last year of residency. And then I also just wanted to mention that even after dermatology residency, although dermatology is a highly specialized field, a lot of residents choose to pursue a fellowship. So by and large, I would say most dermatology fellowships are 1 year. And the fellowships that are most common are Mohs surgery, where you can become a Mohs surgeon, which I discussed at the beginning. You could do 1 year of pediatric dermatology fellowship. You could do a year of dermatopathology, where you can read slides. And, recently, I would say in the past 5 to 10 years, there's more cosmetic dermatology and laser surgery fellowships. Some of these subspecialties require additional board certification, so you may end up taking additional boards to be board certified. Let's go back. Oh, and then another thing I wanted to mention, continuing medical education requirements. So beyond residency, you're always going to be responsible for getting more CME credits. This is part of being a lifelong learner. And then every 10 years, you are expected to take your boards exam to be recertified. There are some other American Board of Dermatology requirements as well. I would say that when you are in private practice and practicing as a general dermatologist, you are going to see a lot of full skin checks. So these are patients who are coming in to get their entire body scanned for skin cancers. While they come in for, maybe this one thing, the full skin check, they may have other issues. So they may have, let's say, eczema or atopic dermatitis. They may have psoriasis. They may have lupus, and you may address these issues in these visits as well. So I would probably say the majority is going to be full skin checks, where you're basically doing a surveillance and screening for skin cancers. And then biopsying any, specimens or moles, let's say, or growths that seem suspicious. And then the other majority or part of what I would see mostly is rashes or chronic skin problems. Just like we mentioned, things like eczema, psoriasis, acne are the most common things.
PM&R, we've got a lot of names to the field. PM&R is basically a field that focuses on restoring functionality for patients and improving their quality of life after any kind of physical impairment or disability, whether that be developmental, whether that be something like a traumatic brain injury or spinal cord injury, or different types of musculoskeletal type problems. Our main goal is to prevent, diagnose, and treat disorders that may produce temporary or permanent impairment. So we focus again on the functionality aspect of it. We really focus on patient-centered care and integrated care with a multidisciplinary team. We try as much as we can to have patients avoid surgery, and that seems to appeal to a lot of patients. Sometimes surgery is inevitable, but if we can sort of find other options prior to surgery that may work for the patient, that's really what the focus is about. And we combine both pharmacological and non-pharmacological modalities. And so we, as physiatrists, coordinate and lead interdisciplinary treatment teams. And we've got great staff. So physical therapists, occupational therapists, neuropsychologists, speech pathologists, recreational therapists, case management, and nursing staff. So we all work together to come up with a plan for the patient and basically sort of see the treatment plan from start to finish, from the time the patient is admitted to the time that they're discharged. And my colleagues all work in very different settings. I work in an inpatient setting, and many of my colleagues either do outpatient or a combination of the two, or really focus more on procedural type. They're in the operating room with the fluoroscopy machine, really working on a lot of different procedures. So it's a pretty vast field. So people often ask, okay, so what kind of conditions do you treat? You sound a little bit like neurology, you sound a little bit like orthopedic surgery, you sound a little bit like pediatrics. So again, it's a pretty broad field, but you can kind of categorize the conditions that we see in different categories, such as musculoskeletal. So we may treat, if you're a sports medicine doctor or a sports and spine doctor, you may treat sports-related injuries on the college level, on the professional level, or just sort of your everyday Joe who comes in with things like back pain, neck pain, knee pain, carpal tunnel. We see patients after they've had reconstructive surgery or knee replacements, hip replacements, amputations from things like vascular disease or diabetes. So we kind of help them get back to function as much as they can. In terms of the neurological aspect, we see a lot of patients with spinal cord injury. That's actually my specialty. But then you can also see patients who have had traumatic brain injuries from car accidents, strokes, other types of movement disorders, multiple sclerosis. And we also see patients who've been debilitated. So patients who may have undergone a CABG or a bypass surgery for their heart, or who suffer from COPD. And most recently, people who've had COVID, who've been in the ICU or in the hospital for a really long time and have a lot of myopathies and muscle issues and are just very, very debilitated after being in the hospital for a long time. So we're starting to see more of those patients. And there's also cancer and pediatric patients that we see as well. So in terms of the training for PM&R, So in general, there's 4 years of medical school. That's pretty standard for everybody. But residency really consists of 1 year of internal medicine, a prelim year. So either internal medicine, you can do surgical, or you can do a transitional year. Now, some programs actually have a categorical program, so it's kind of built into the same system. But for the most part, you're doing a 1 year prelim in a sort of more general area. And then after that, you're going to complete 3 years of PM&R training. If you decide to, so after that, you can practice, but a lot of people decide they want to do a fellowship to further specialize or subspecialize. And so our fellowship programs are typically 1 to 2 years. I personally did a spinal cord injury fellowship, which was 1 year. But there are a lot of different areas, and everybody has different interests. So you can do interventional pain management, which is something that's either a PM&R program, a family medicine program, and some anesthesia programs actually accept PM&R students. You can do sports medicine, which might be sort of get into that emergency medicine programs as well as family medicine. But a lot of people really love sports medicine as well. There's brain injury. There's sports and spine, which is a combination of sports medicine and the interventional pain. You can do pediatric rehab and deal with patients who have developmental issues, cerebral palsy, things like that. You can also go into some non-accredited programs like cancer rehab and multiple sclerosis, or you can sort of, go another route and do like hospice and palliative care. So quite a few options for people based on their interests. So in terms of my day-to-day life, I do mostly inpatient. So I will get to the hospital and I have a service of patients. So I will round on my different patients. I like, for the most part, to see them during their physical therapy or occupational therapy. It gives me an idea of what their functional status is and allows me to really communicate with the therapist on what the update is, if they're having any pain, if they're having any change in their functional status. So I tend to see patients when they're in the gym and talk with them and round. I have interdisciplinary team meetings with the group of people that I talked about earlier, just to kind of discuss care plans for patients. I talk to families. A lot of times we like to have families come in and do rehab or kind of witness rehab with their their family members, just to do family training, sort of to better prepare them to go home. So it's really interesting. I will admit patients to the hospital, either from the acute hospital or sometimes even from home if they're having a change in function. Other parts of the hospital, other services, whether it's ortho, trauma, internal medicine, often we'll put in consultations for, pain management, or if someone has a spinal cord injury. There might be some neuropathic issues or nerve pain issues that they have, and really just trying to see what we can do to get them over to the acute inpatient rehab side so that they can have intense therapy. And I don't currently do this, but a lot of my colleagues will also see patients in outpatient. So patients who are either discharged from the hospital, they will follow up and sort of do sort of chronic pain management, or, we'll talk about bowel or bladder issues or any kind of pain related issues. So a lot of different options.
So here's my presentation I have for you guys. So you want to do cardiology. So what I'm hoping to do here today is to give you a little bit of insight on how you get to become a cardiologist, what's the training involved, what's the various avenues you can take after you go into cardiology, because there's cardiology, but now in this day and age, we're really compartmentalized and subspecialized into numerous different facets of cardiology, which makes it so interesting and exciting, and there may be something for everybody there. So we'll talk a little bit about that, the training and the time of training involved, and a little bit of insight of what my job is like. And then we're going to go over sort of a typical type of bread and butter case for someone in interventional cardiology like myself. Okay. So becoming a cardiologist. Well, First thing you got to know, there is a lot of schooling and training involved, right? And there's some fields that require less training. Interventional cardiology is pretty much the same as becoming a neurosurgeon, and there's a lot of training. So you obviously got your 4 years of undergraduate, you got your 4 years of medical school. There are 7-year combined program options, which I had considered at one point. In retrospect, I wish I had considered it strongly because, like I told you earlier, every year counts once you hit your 30s and 40s. Training, so 3 years of internal medicine residency, 3 years of cardiology fellowship. For the most part, there are some programs that have a sort of combined internal medicine fast track cardiology where they do it in 5 years. There's not a lot, but there's some. There's also some on the opposite spectrum cardiology programs that have 3 years plus 1 or 2 research years if you really want to go the intense research academic route. And so, it really depends what you're looking for. After general cardiology training, then there's further subspecialty training that can happen, which is 1 to 2, maybe even 3 years, depending on what you're looking for and what type of specific subspecialty you're interested in. And then there's always the optional research years that you can do. Some people tack on actually additional years in between residency and cardiology. For example, sometimes people don't match into cardiology, so they do some other ancillary cardiovascular imaging or echo or some kind of training programs you can do before fellowship, actually. So there are options for that. So there are a lot of different ways to get to it. And of course, other extra years, a lot of people do a chief residency year that acts on an extra year. Doing a chief resident year definitely improves your application, your chances, particularly if you're looking to stay at your own particular program to carry on. And again, we talked about the research years. And, I took a research year between college and med school. Folks do that. And, that's something to discuss with your college advisor if they feel your application could warrant it. Definitely one of the most competitive specialties. And we talked a little bit about this before, a lot of things that do matter. Obviously, medical school and your scores in medical school are very important. The residency program you go to is important. Your UCMLE scores, although this day and age now we have a pass-fail for UCMLE step 1. So things are changing a little bit there. Research experience and letter of recs, perhaps even more important now with the pass-fail of USMLE. So, and this is always a moving target. And this is just a small snapshot. There's a ton of other things and ways to sort of help improve your chances of getting into a cardiology fellowship. So talk a little bit about cardiology subspecialties and the training involved. So we talked a little about the cardiology fellowship, right? So that's 3 years in general, okay? A lot of people, I don't know the exact numbers, how many people actually go into subspecialty. It definitely varies by year to year. Interventional cardiology, clearly one of the more popular and still probably the most common subspecialty in cardiology that people choose. In general, bread and butter interventional cardiology is 1 year. And sometimes extra training for an additional 1 year if you want to do more advanced training. So, when I was there was just interventional cardiology. Now they're having more accredited programs for additional training for structural interventions, and she'll talk a little about that later, and peripheral vascular procedures as well. So there are various models of additional training that can occur. Then there's the second most popular subspecialty is electrophysiology, right? So, interventionals, we're the plumbers of the heart. The electricians are obviously, the electrophysiologists rather are the electricians of the heart. That is now, used to be 1 or 2 years. Now it's pretty much around the board 2 years. So you're looking at 2 years of training if you want to do electrophysiology. What's becoming more and more popular also these days is advanced heart failure and transplant, right? So those are, and we'll talk a little bit about what they do, and most of those programs are also 1 year. And then advanced imaging specialists. With the advent of more usage of cardiac MRI, we're seeing a lot more of these trainings pop up as well. So that's also an additional year for cardio advanced imaging. Okay, and then there's other niche specialties. Some of these not all of them have accredited training programs, but you can find some non-accredited ones for more niched training, and that can include anything from adult congenital heart disease, cardio-critical care, which is a lot of people have been combining cardiology fellowship with a critical care fellowship, and there's actually like additional training after cardiology to do critical care. Cardio-oncology is also becoming, buzzworthy these days. Sports cardiology, this is just to name a few. And there's even subspecialty things that programs make up on their own and train people in. So you can really sometimes find a really innovative and types of niches of subspecialties if you look around for it.
The urology day-to-day, Sam asked this earlier, what does the lifestyle look like? It really depends on your specialty. And so there's a lot of different subspecialties within urology, which is surprising because urology is already a pretty subspecialized field. But it ranges anywhere from general urology to pediatric urology, oncology. And the specialties that end up having more demanding hours are those that take care of sicker patients. So the oncologist, the urologic oncologist. Whereas general urology, men's health, female urology, a lot of that is outpatient based. And so I would say the majority of urologists are working pretty good hours. But regardless, it's still a surgical specialty. So the hours are, even as an attending, are pretty demanding. I put down here that 40% of urologists will complete a fellowship. And that's just to highlight the nature of the subspecialization of the field. And one great thing about urology is it is a mix of outpatient and inpatient. So, you have clinic patients, and then you get to operate, and then some patients are admitted to the hospital. And so you get that really nice variety. I know that if I was in clinic 4 or 5 times a week, it'd be very tough. I'd burn out pretty quickly. And so having that variety of OR, outpatient, inpatient is a great aspect of urology that not a lot of specialties have. And another awesome thing about urology is we essentially own each organ that we take care of. So the prostate, the bladder, the ureters, the male GU tract, the kidney we share with the nephrologist. They'll take care of the medical portion. We take care of the surgical portion, but the surgical portion is much more fun anyways. Whereas everything else, we take care of both the medical portion and the surgical portion, which is really nice because, if you're a cardiothoracic surgeon, you have to share patients with the cardiologists who may be kind of impinging on your field with interventional cardiology. So those are some factors to consider in terms of job security. And there are a lot of different types of urologic practices, whether academic through university or public hospital, or private practice group, whether they're large or small. The days of the single solo practitioner, especially as a surgical specialist is kind of dying because the overhead costs of being a surgical specialist that's solo is very expensive. And a lot of urologists these days are going into hospital-based employment. And so they don't own their practice, but they'll be employees of the hospital system. And so, this is not something that a lot of people like talking about, but your salary is a big part of your job satisfaction, and not necessarily because of how much you actually get paid, but how much do you feel like you deserve and how much are you actually getting paid. And so the highest likelihood of burnout is if you feel like you deserve to get paid more, but you're actually getting paid less. And thankfully, as a urologist, you're usually not hurting for money. It's always in the kind of top 10 of most well-paid specialties. But part of that is that urology is a surgical field, and you do typically work a few more hours than a medical specialist. And just a few points, similar to OB/GYN, there is a gender disparity in urology. It's the opposite of OB/GYN, essentially, where most of the practicing urologists are male, and you see these percentages here. It's the rising percentage of female urologists, and I think this is something that the field is very aware of and wants to increase the diversity of our field. And so it's a great field for women. It's a great field for anyone, honestly. And so I know that we, as in my residency, we're very supportive of the women in our program and want them to be successful. And so this is just a thing that you should be aware of. I think any woman who's applying to urology should understand that there is a gender disparity, but it's not because we don't want women in the field. We definitely do. And so the training, it's a surgical subspecialty, and each urology program has anywhere from 1 to 5 residents per year. And obviously, this is drastically different from like an internal medicine program that has 50 to 100 spots per year. And that's part of the reason why it's so competitive, not necessarily because the field itself is inherently competitive, but because there are just such few slots. And there are 5 clinical years, including 6 to 12 months of general surgery during intern year. And depending on what you think about general surgery, those are some very good times, or they can be very bad times. But overall, intern year is actually probably the lightest year for any urologic residency. And each year, people say that each year gets better, and that's definitely been my experience. There are a handful of programs that are more academic that will include a 1-year research, usually after the 3rd clinical year. And on average, as a resident, you will work about 60 to 65 hours per week. And that's not including call. And compare this to a medical specialty, medical like internal medicine will work 50 to 60 hours a week. And so definitely there's an increased burden of work. And depending on what kind of program you go to, you may be on home call, or you may take in-house call, and whether you get a post-call day depends on that. But typically, as a junior resident, you're on call every 3 to 5 days. And so that's for your entire year. It's not just for one rotation, that's for your entire year. So because urologists are few and far between, we do have to cover, and we need, the call at every hospital is not super intense. And at my program specifically, I think that the call is difficult, but it's very educational. But the call burden definitely decreases as you become more senior. And there are many programs where you don't take any primary call as a chief resident, or you're in your final year. So for residents, for example, my program, we take home call. So we actually cover multiple hospitals from home. And then there are some programs, going back a second. When you're in-house, when you do home call, you don't get a post-call day. So theoretically, you could work all night and then work the next day, another full day. And so that's a danger of doing home call. But typically, programs will do this because the number of nights where you're up all night are pretty limited. And I would say for me, I'm probably up all night maybe 3 or 4 times a year. And so it's definitely not as common, but there is a risk of that happening. And then if you're in-house call, meaning you're in the hospital, you have to physically be in the hospital for the 24 hours or 30 hours, but then you get a post-call day, meaning the day after you get the day off, essentially. And so that's the difference. And it depends on what kind of programs you go to. The programs that are on the West Coast are typically home call, and then programs that are in the Central United States or Midwest or East Coast, where it's surrounded by the major hospital, like Hopkins, for example, or a Cleveland Clinic, they'll do in-house call because they only have to cover one hospital, not multiple hospitals.